The chair is in the house. Plug it in here. You gotta look at it.
Okay. Um, I see Senator Gray here, so I feel compelled that we should probably talk about 661 first, because we might be here all morning. You have nothing else better to do than watch what we do all day? So, why don't we take up 661? And so I would invite the insurance department up to tell us where we are with 661. Okay,
Working on it.
right, so you're doing everything in the other bill. So at this point, as far as you're concerned, we're just past 661, like the Senator. As you know, I'm worried about transition between, someone goes
Yeah,
one from
because
the
we're
other.
still working on the other one, I would just say cautiously hold it for now.
Oh, yeah.
Just in
Okay.
case there is any minor tweaks so that the language lines up.
Okay.
Right now, we're trying to work around the language that is in 661, so there aren't any changes that need to be made, but if it's not going to hurt anything to keep it
Yes,
a little bit
we can-
longer, we
can
would.
certainly hold on to it.
Okay.
Okay. You okay with that, Senator?
Certainly holding on to it is better than doing something detrimental to it. The email that I sent you, I don't know if the committee's got it, about the work that we've been doing on 1491 with the insurance department. They stated in the meeting with me that their original draft was for an accessible model. Okay. that they wrote in 1491. And since that's not what the one risk pool that has said that they want to go to a 1491 model said, there's changes that need to be done. All of the transition, because Senate Bill 661 does not have, no one's trying to go there, okay? We still have the way that you can create one if you want to, but all the transition is in 1491, which was one of the questions that Health Trust had. But it is my intention that both bills will pass, that, I will not kill your bill when it comes over. I will at least ask for a committee of conference to work out any differences, which is the thing that could be done if there's minor tweaks that need to be done. If you passed it now, we could work out those tweaks in the committee of conference, but it's your bill right now. It's not my bill.
Okay.
So,
Right, well, we can certainly hold on to it until, when we get closer to seeing what needs to be done.
I look forward to seeing you on the last day to sign for committee conference reports.
Well, I'm good to hear that you're taking a different approach than you did last year, which you said that you didn't want to go to any committee or conference. So
Well,
that if you're
That-
giving you the
that
having
had
the
to do with
opportunity
a
to go to committee.
conversation that I had with last year's chairman in the hall, where he said that the only model he would accept would be an insurance model. And so if there wasn't any point in going to the committee of conference, then, but this year, right now, we're going dual paths. The people that want to stay with the model that's out there right now in 5B can stay there. The people that want to go to the insurance model, after the insurance department determines what really needs to be there to protect the people that are being insured and to ensure the solvency of it, which is the only direction I've really given them
That's their
in
job,
writing that.
solvency.
to get there.
So I'm not sure what chairman you were talking to, because my memory is the bill that I sent back to you had everything of 5B still in it. So I was not
The
taking
1490
5B out.
The 1491 did, but
Yes.
last year's bill did not.
No, it did. It actually did. It actually had 5B in it.
Well.
So notwithstanding that, I'm glad we know we're on the right track and we'll get there.
Amen.
Okay. Any other questions to the committee members? Seeing none, thank you very much. Okay, so at this point, we are holding,
Oh, yeah. Oh,
hold.
okay.
Okay. Is there any other senators in the room? Okay, good. Then we can move take it from the top. Okay. Senate Bill 256, establishing safety care requirements for clinically administered drugs. Okay, so this is the white bag, brown bag. We've had this issue of multiple years, and we've never passed it. I don't know what's really changed on this issue. So, Representative Spear.
We're in subcommittee, right?
Correct.
Okay. So in that way that I have of reading all kinds of minutia, we received a table from the hospital association showing a bunch of drugs that were were cheaper by going with the hospital pharmacy.
Right.
The insurance department, and it looks like Dr. Az's because it's his writing or sound, put together a list that the other list is a subset of.
Okay.
And that if you look at the full list, which came from the insurance department, it looks like, yes, there are some drugs that are cheaper and some drugs that are more expensive, but overall, if you add it up, which I did, you come out cheaper if you go with white bagging. So the question is, we seem to need both. We need to leave things the way they are so that negotiations can happen and we can end up with a better price mix, as we see in the insurance department memo.
Okay.
Mr. Chairman,
Yes, Representative Miles.
thank you. Indeed, that is true. We also need to consider the testimony from the 3 pharmacists that were in the room that day. And think about the chain of custody and all the particulars that lead to potential safety interruptions. So although I do agree we need to balance the cost, we also need to think about the safety implications and whether the drug is being delivered in a timely, safe manner, it's being kept at certain temperatures, and clinical efficacy issues. So that's my part.
Right. Well, the most compelling thing I heard was that Anthem was actually, had a contract so that they were using the pharmacists. And since they're the lion's share of the small group market, it feels like to me that at this point, there's not any particular need for us to pass anything. So the issue is whether we want to keep it around just to keep an eye on it, with interim study, or should we make it ITL?
I think interim study would be
Okay.
very nice.
So Representative Miles. Moves, second by Representative Petusek, interim study. Any discussion on that motion? Okay, so who's on this? We got Berselli, Miles, myself, Thaxton. Sharice is not here. Herbert is here. Spear is here. Okay, so all those in favor who are on the insurance committee, say aye. Aye. You're not on the committee. So we got 1, 2, 3, 4, 5, 6.
6-0.
Okay. Moving right on. Senate Bill 455 relative to health plan coverage of GLP-1 medications. So then again, this is just for Medicaid. I always have to worry to get it right. This is just for Medicaid, and the governor had just done said we can't afford it. So at this point, we certainly can't pass it because the governor will veto it. So, yes, Representative Spear.
Thank you. I do have a couple of questions, though. Can we get somebody up here that knows about this stuff and how it works?
How
I have 2 questions about.
GLP works?
Well, I wanted to know, how does the provider determine who should be getting it? And the other one that I have, and I've been writing them down. And I especially want to know how do you stop it? Because I haven't been able to stop it.
Well, the
Uh,
provider
yeah.
is typically a bariatric/obesity specialist.
Yeah, I got one of those.
Right.
I'm still losing.
So they provide-
I'd like
so-
somebody up here who knows what they're talking
They
about.
prescribe it.
Right. I think at this point, that one is the issue of the GLP is that you're potentially on it for life.
It's not as easy said than, it's not as easy
I
to
said
be said than done.
potentially.
It seems to be very difficult, at least in some cases, and my case, to maintain an even keel on it, even at the lowest dose. And I haven't figured out how to stop.
Okay, so I think you should talk to your.
Oh, I will. But I thought we have so many experts here.
And
I thought
asking
somebody
for
could answer.
asking for free healthcare.
No, yeah, well, yeah, once in a while you do.
It's probably not the best thing to do.
Well, this stuff is very expensive, so you gotta get the free where you can.
Okay, does somebody want to make a motion for me?
Can we interim study
ITL?
this?
I want
Yeah.
to ITL it.
Uh,
I would like to ITL this bill.
Okay, Representative Purcelli, seconded by Representative Petusek, moves.
I would
And-
like to interim study it.
Well, right now we have an ITL motion on the floor.
Okay.
Okay, so, we have it moved and second so you obviously would urge everybody to vote no on this pending motion.
Yes, because as time goes on, we should keep it open so that we can see the additional long-term benefits that come about. And we can also figure out ongoing maintenance pricing. And I mean, as a matter of course, after reviewing lines and lines of claims data, the most I've ever seen any commercial plan, I know we're talking about Medicaid, but this is important. Commercially, the most I've ever seen a plan pay per month is about $1,250 for the most expensive one. That's about $14,000 a year. So one night in a hospital is at least $2,000. So a person ends up having a heart attack or long-term diabetes complications, kidney disease, dialysis. Those things can run in the hundreds of thousands of dollars. So we're talking about $15,000 a year, $14,000 a year to, long-term serious health consequences with major surgeries, open heart surgeries, dialysis. So all of those things are the result of chronic disease, which we have heard from the professionals, the doctors, that these drugs can mitigate. So I think it's important to keep the studies going and the conversation going. And I think as we see these drugs help more people, we will have maybe a change of heart from the corner office.
Representative Purcelli?
I respectfully disagree. I understand that we've got an obesity epidemic in this country, but I'm just very concerned that increasing these medications where there may be no end point, we're not sure what the long-term effects are. Overall health may improve because you're reducing your dependence on other medications, may be well and good. But I think the overall long-term effects of this, combined with the processed food industry that keeps creating more people with more problems that will need more drugs. This is a free market solution. There's a big problem with obesity. The drug companies that are making billions of dollars off of this have come up with a solution, and I just feel that this is not the right course of action with the expense on this bill. But I understand that there could be some benefits from it, but I am very concerned about the whole structure of it.
Representative Thaxton?
Well, I agree with Representative Porcelli, and I agree with Representative Miles. I think that this is, I think that at this point, the solution is to ITL this. And I'm absolutely sure that this bill will come back to us next year, and we will have more data. There is clearly the case of, it's only $14,000 a year, and if that was for one patient, that's not that bad. But if 2/3 of the state of New Hampshire decides they're entitled to coverage, that's a problem. So I think until there's more depth on it, I think we're poking our way through this development. So for today, my vote is to ITL it. Not because I'm opposed to it, or I find it morally offensive, or I'm concerned about Kerry fading away. It's just, right now, that's where we're at.
Okay, Representative Spear?
I kind of agree with Rep. Thaxton. We can bring this back next year, and if everybody wants to study it, anyone who wants to study it and come back with a good bill that we can afford, that would be great. But we don't have to interim study it in order to have it come back next year. And they're only 2 months apart or 3 months apart. The interim study is due at 3 months ahead of bringing a new bill. So it's not like you're going to lose a lot.
Okay,
Well,
any
I
more
just don't want to be
discussion?
penny wise and pound foolish.
Well, I would actually say that the one thing you didn't factor in is that in lieu of having GLP medications, you could get bariatric surgery, which we have mandated already that is available. And bariatric surgery, I would say at most might be 2 years of that. So the 14,000. I don't know if it's going to be less than 14 because surgery is expensive. So,
Well,
but
it's
it's
about
certainly be less than
$30,000 without
years.
complications.
Yeah. So, okay. So the motion is inexpedient to legislate, and I think everybody in the committee knows who they are. So those in favor, raise their hand. 1, 2, 3, 4. And those opposed, 1, 2. Okay. Okay. ITL 4-2. Okay. At this point, I'm not worried about it. All right, limiting certain prior authorization requirements for physical therapy, occupational therapy, similar rehabilitated services. Okay, so this one, where I guess what this bill does is it questions whether the legislation we just passed, which is asking, which was, I think, getting approval is with 72 hours, the approval has to be done within 72 hours.
So I think you're referring to SB 561 that
Oh,
was
I'm on the
passed a
wrong
couple
one.
sessions. Well, no, that was the bill that addressed prior auth a few sessions ago. That's
Right,
now
yes,
implemented.
okay.
So that was related to prior auth generally.
Yeah.
I believe this bill is specific to those PTOT services
Right.
and putting in restrictions on when prior auth can be applied.
Right, exactly. And so it kind of, as though it questions what we did with that prior auth by saying is, oh, no, that, and am I correct about 72 hours? That it has to.
It's 72 hours if it's an urgent situation.
Okay.
Otherwise, if it's submitted electronically, it's 14 days.
Okay,
We did just post recently because of SB 561, there was reporting requirements that were required to be posted online. Those are now posted on our website, and it has some metrics for prior auth for each carrier specific. And I would say just generally speaking, the majority of prior auths are approved, and on average, prior auths take about 2 days to process.
2 days anyways.
On
Right, because you're
average.
doing everything electronic now. It's like prescriptions.
That's the
everything's
hope. There's still a non-electronic process, but the timelines for that are longer because it takes longer time to process those.
Process, right, okay. Representative Spear.
There was another aspect to this that seemed to be pretty important, is how often they need to have prior auth. Right now, it was like five sessions in, and they wanted to change it to 8 sessions in.
Right, well, this bill now is 8.
The bill is 8, but we haven't changed any.
No, at this point, that
Should we?
change it to what?
8,
Right,
like the bill wants.
right. I just don't see any need to change it, but do you feel a need to change it to 8? Or create 8? I mean,
Well,
what is it now? What is it, right
5.
now for physical therapy, what is the?
I think it was 5.
It's 5. Is that with the current? I don't see any. I don't know if it says replace, but
So
go anywhere.
the
Just
amount
stay
that
right
the amount of sessions that gets approved depends on the clinical guidelines. So it's not just one catch-all for all of these services. It really depends on what's the underlying reason that you're seeking treatment, and whatever the clinical guidelines are for that is what would get approved. And so this would apply a blanket amount of sessions that is not taking into account the underlying diagnosis and treatment guidelines.
Right. And because I remember someone said that carpal tunnel was only took 2 visits. So
I don't.
I remember
Beyond my
that-
knowledge, we don't
right,
have data.
I think
on
I
that.
heard that
Yeah.
in the hearing. So at this point, I don't think we should pass anything. Anybody else feel any different?
I have just concerns about the patient, not the carpal tunnels, not the knee pain, but I have concerns about patients who are in acute situations, who just had a stroke, who are moving to outpatient rehab and need those services immediately post-discharge and have to wait for a prior auth, because when, post-stroke, you have limited time to regain certain functions. And so for things like acute stroke, head injuries, I think that this bill makes sense to have the 8 visits without needing the prior auth. I'm not saying not a referral, but for acute events, and maybe there's someone in the audience that can speak to
Well, I
this.
assume that's why they had the 72 hours for speedy service.
Yeah, if it's an
Perhaps.
urgent situation,
Urgent.
72 hours.
That's where the 72 hours came in.
So that's my only concern here.
Yeah, but we don't, I mean, that, law just went on the book, so I hate to.
The
go mucking
72
with it
hours
now.
has been there for a while.
Oh, the 72 hour,
So
okay.
that didn't necessarily change. It's the non-urgent situations that those timeframes
Okay.
shortened.
Right. Okay. So, anybody interim study or ITL? Okay, Representative Thaxton moves inexpedient to legislate. And that's second by Representative Too sick. Because, oh, that's right, I keep using you and you're technically,
I'm subbing.
you're, I don't know who you're subbing for, okay. All right, so, second by Representative Hunt, so for this purposes. Okay, any discussion on the motion of inexpedient to legislate? Okay, all those in favor say aye. 1, 2, 3, 4, 5. Those opposed? Representative Miles?
As long as the 72 hours for the acute patients is actually in law
Yes.
currently,
Yes,
I would agree to ITL.
okay. Great. Okay, moving right on. Relative to children's mental health services for persons 18 of age and younger. Oh, this is the hot one. This one must be half the room. Okay. So at any rate, we now have, I sent to everybody, email to everybody, the smoking gun that I was like asking during the hearing. I kept saying, who was in the room? How did this happen? You know, how did this all go down? And as we were able to trace, this all happened in the executive council. The legislature was never involved. And this happened at the executive council level with the approval of the contract with NFI, if I got it right. So in that contract, it turns out the expectation was that NFI was supposed to be billing the private insurance companies when they included private insurance kids. The expectations they would be billing them in that, and that was what the expectation was, and that was written in the contract. And for the defense of the executive counselors, I'm going to assume that that's what they were thinking. So my understanding is that issue has been somewhat aware that everybody knows this is about a contract issue, and that's been hanging around the last couple of years, and that's why this bill has been introduced to the Senate, but didn't get anywhere when it was in the Senate. Because they kept hoping that a contract would happen. So that my understanding is the reason in terms of the pushback on the contracts and why contracts are somewhat problematic is that insurance companies are used to having contracts with providers. And let's say that in this case, it would be a mental health provider. But NFI is technically not a mental health provider. They're just providing the wraparound, the what I would call care management, and which is in that care management was all kinds of things, including the one that really got me was setting up respite. Okay, and so notwithstanding, the question then becomes that maybe that is what the issue is and why the contract has not been done. Why they're, what in terms of the insurance company. And so my attitude is that I have made it clear to the insurance companies that I expect them to sign a contract, get a contract done. And if the issue is that you need to have a code, the code to figure out how to reimburse for NFI, I would say is we will. I would like to interim study this bill, and so that when it comes September, if that's the issue, then we will absolutely recommend legislation to require that you have to have that code, and that way we can get this problem solved. In terms of the mechanism, the funding mechanism, I was absolutely in the room when that was created. And I have a long history because I literally was acutely aware of each time it was used or implemented or voted upon. And so all I can say is it is a very unique situation. We don't want to ever go there unless it's in our minds, this is ultimately what we really need to do to address a problem. When it came to the vaccines, it was, even the insurance companies thought this was a good idea because the government was able to having it run through this nonprofit, the entity that we created, was actually getting the vaccines cheaper than any other way. So in that sense, that made sense. In this particular situation, I don't think we're there yet, but I certainly want to say to everybody in the committee that if you ever hear this idea about, oh boy, you got this mechanism that was created by Roger Savini and John Hunt years ago to assess companies, please tell me, run it by me before because it was just at that moment we were in a crisis situation with the individual, the non-group market, and yes, we felt it was important to subsidize it. But at this point, I hope people won't use that plan, use that model ever again. But if you really feel that you have one, then please discuss it with me because I have very strong feelings. And I would say that the third time it was used was for us to fund the marketplace, where the expansion of Medicaid under Obamacare. And at that time, I actually voted against it. Okay, but I was in the minority, and it did pass. So that mechanism was used for that third opportunity. So I do have very strong feelings about that using that mechanism. With that, I would like to move interim study.
I just have a quick question about
Yes.
this. I'm not really
Well,
quite.
first,
Oh, I'm sorry.
is anybody going to second my motion? Okay.
Yeah,
Now,
I'm fine
okay.
with that, but I still don't quite understand the funding mechanism and how it would impact that small commercial market, right? Isn't this for covering?
This
the
is covering
commercial
something
market?
that's actually, we're saying that it needs, the
Another
commercial
mandate.
should be doing it. In other words,
Right.
if the kid has insurance, is under, into the, let's say, ERISA or the small group market or whatever, that yes, that the insurance company should be reimbursing for it.
Okay, but
Okay,
I'm just
it-
not sure what the impact is on the, per member, per month, per year. What will this do to the premiums?
Right. I would
for-
say
I-
what
it's
we've
a very
heard.
important program.
No, I
There's
hear
no
that.
question about it.
Yeah.
But we're passing a lot of mandates, and then when we question, well, why is health insurance so expensive in the commercial market? Well, because we passed, 5 new mandates.
Right.
So
In
I'm
this
just
case, I
curious
would not
about this.
necessarily call it a mandate because we already have the mental health parity. We already have the requirement that parity has to exist. So we're not, at this point, we're not mandating anything new. This is something the insurance companies should have been paying, doing all along.
And they're already, so the premiums are already covering
The
this.
premiums theoretically, that always brings up the conversation of minimum loss ratio. Okay, and minimum loss ratio, as you know, we've talked about before, is what drives the premium in the end. So the question is that now that the insurance companies would have to cover this, I would say that insurance companies have in their plan, the actuarials have to take in consideration mental health, but would they be able to raise premiums based because of us doing this? And the answer would be no. Okay, the only way they would raise premiums is that once they start paying it, okay, which they should have been paying all along. Once they start paying it, then it potentially could raise the minimum loss ratio.
Okay. I
but-
mean, it's an important program, but I want to understand.
Yeah.
How this is going to affect that very small slice of the commercial.
And I'm glad you bring that up because, we in terms of how many mandates we want to pass, because, we got at least a dozen bills here and we had, the
Don't
prosthesis
forget the
and we
legs.
had the natural pass. Actually, I think the natural pass will save money.
That's next.
That
Okay.
the natural pass will save money.
Mhm.
But in terms of the prosthesis, that obviously is an added cost. But, so the key thing is to try to keep it to a minimum, correct?
Right. I
But
mean, it's an
whenever you do
important-
something that has a real huge impact, then,
Yeah,
then
it's
yes.
a very important program, but I just want to make sure that we're looking at potential unintended consequences.
Right. I absolutely appreciate your
All right, thank
focus.
you.
Yes,
May I just make an observation?
yes.
Just an observation. My pattern recognition is going off whenever I hear this mandate will save us money. This mandate will save us money. We hear that over and over.
That
and
is
over again.
true.
And we'd all be very wealthy if all the mandates saved us money. So when I hear that, I'm a little skeptical.
Okay, so
Yeah.
I will, when we get to it, I'll tell you why.
Okay.
Okay? All right. Yes, Representative Walsh.
Thank you, Mr. Chair, and I realize I'm not on the subcommittee, so thank you. Can you just run it by me as to why we're not OTPing this versus interim study? Because, I mean, if it's because we need the insurance companies to get on board, I mean, they've been,
Excuse me? What's that? You would like to take a recess?
Yes, Mr. Chairman.
Sure, we can take a recess.
okay.
Okay, the terms of passing this, first of all, this is a very awkward situation that you are firmly
Do I have to
knowing
put the
which bill were? No, the one we were doing was 498. And so at this point, we are recessing our conversation to the end of.
Okay, but was there a motion on the floor before that?
Even if there was.
Oh,
we
okay.
still, you know, in other words, we could say we're tabling it, and the pending motion is, if there was a pending motion. Did we actually have a pending motion? Okay, so we did, so yes, so we are, we're holding off on that, and we'll wait until, okay? All right, next, all right, now,
Okay.
544. We got a fiscal note here. Okay, 544. Okay, so what is this one about? I told you shouldn't move away from there.
So this bill was amended by the Senate, and it makes some changes to 420J with respect to prescription drugs to make some of the notices larger, so consumers are more aware of the exceptions process for prescription drugs. It also further explicitly states that a denial of an exception is an adverse determination that can be appealed, and it makes some changes to some of the documentation that carriers are required to keep.
So this one isn't that if they change the formulary in the mid-cycle? is that-
That's how it started, and this is the amendment.
Okay, so does it still have that in this bill?
No,
Okay, good, because I didn't like
it's more
that.
about notices to consumers
Okay.
and making sure. I think it does extend time frame slightly so that they can't from 45 days to 60 days when there is a formulary change.
Okay, okay. Does anybody have a problem with this bill? Oh, okay. Come on up. Good morning.
Good morning. For the record, Holly Stevens, Director of Public Policy at NAMI, New Hampshire. As you remember, you folks were just getting ready to scoot to lunch when this bill was heard, so I was very brief in my remarks. But attached to my testimony, I did include a proposed amendment that essentially what it would do is if somebody was on a medication when they received notice of the deletion, and they applied for the exception, that the exception would be automatically granted. I have spoken with the insurers. They are split in whether they like that amendment or not. There are some that do and some that don't. So I will leave you with that. But
Okay.
yeah, we would appreciate if folks were able to stay on their medications.
Well, I certainly appreciate that, and I'd be willing to put a bill in for next year on that subject matter.
I will be in touch.
Fair enough. Okay. So, anybody want to make the ought to pass motion? Okay, I move ought to pass. Okay. Herb was ought to pass. And second, any discussion on the motion of ought to pass? Seeing none, all those members of the Health Insurance Committee say yes, please say aye. 1, 2, 3, 4, 5, 6. Okay. Okay, next up.
Wait a minute, do we have the amendment?
There was no amendment. She was offering an amendment
okay.
concept, and I told her that I would prefer to bring that in as a separate bill next year. Okay. 550 is the next bill. Okay. So, all right. So I will move ought to pass, and seconded by Representative Spear. And here's the reason why I say it's going to be cheaper, why it's going to save us money. Where normally I agree with you, mandates don't necessarily save money. But in this case, what's interesting is that Natural Pass are reimbursed at the same rate as nurse practitioners. They're not reimbursed at the same rate as a full doctor.
Because they're not full doctors.
That's true. They're not full doctors. They don't have 6 years of care. They have 4 years. So the whole reason why I wrote, were you here for the hearing?
I watched it.
Yeah. Oh, you watched. Okay. So the whole reason I had put in May was because at the time the medical society was concerned that they didn't want them to be at the position of full doctors. But but that may help us set the stage for us now to find out that the reimbursement rate is actually less. So therefore, a naturopath would, if people choose to go to a naturopath, they really would be saving us money.
No, it's so that they can bill at the higher rate. And that's not saving us money.
No.
Yes.
Well, how does it say that? No,
If you take a naturopath and you put them at the level of an MD, that means they can
we're
bill
not
at a
putting
higher
them-
rate.
Okay, that is your opinion.
No, that is a fact. They
No.
can bill at a higher rate. If you see a physician, they bill at a certain rate. If you see a mid-level, they can only bill at a certain rate. So this is more costly. This will make it more costly.
Okay, that is your opinion. I do not agree.
It is a fact.
Okay. Okay. All right, so the motion is ought to pass. Yes.
Sorry, in my notes, I have that we may want to change the effective date. Does that matter? at
Oh,
all?
you're right. You're right. We want it, yes. Okay, so, yeah, so we want to change the effective date till upon passage.
Yeah, 1/1/27.
What's the difference?
It gets it into the billing cycle of insurance companies.
The current year or something?
Yeah, exactly. Okay.
Yeah. Instead of
That is
60
correct.
days.
We should have a scoreboard of this mandate will save us money and then check
No, all,
yes or no.
most mandates are. I
We should
mean,
keep
but this one is, I guess, in terms of, it's incremental, in terms of, what are the real costs. I would say it's probably going to be, I mean, whether there probably is some people out there who the naturopath is their primary, okay, and they haven't been getting, the insurance company to reimburse it, okay? But that's very few and far between because most of the insurance companies did cover them. The oddball one, I think it was Cigna, was only had 8 in their network that they actually had.
So it's a one-word bill, and it was May, and so most of them were already doing it, is that what you're saying?
Yeah,
And there's-
most insurance, the insurance companies were already covering it. Exactly.
Can we have someone from the department to talk about, at the witness table, to talk about the billing aspect on the new rate if this bill passes?
Michelle?
So I'm looking at the bill right now, and give me a second because it's tiny. But what it's doing is it says each insurer that issues or renews any policy of group or blanket accident or health insurance providing benefits for medical or hospital expenses shall provide to each group or to a portion of each group comprised of certificate holders of such insurance who are residents of the state coverage for expenses arising from a health service performed by a doctor of naturopathic medicine licensed under RSA 328E if that particular type of service is within the scope of practice of the doctor and if the insurer would reimburse for that type of service when performed by any other type of healthcare provider. So what this is really trying to do is saying that if whatever the service is that this naturopath is doing is already a covered service, and if you had gone to another healthcare provider, it would have been reimbursed, this law would just be saying you have to reimburse that naturopathic provider. It is not a true benefit mandate in that it's not requiring any specific services be covered. It's linking it to services that are already covered under the plan. It also doesn't say anything about reimbursement. So whether the carrier wants to contract and whatever the negotiated rates of the contract, none of that stuff has changed. So from our perspective, we don't think it would have much of a cost impact. If anything, it could encourage naturopathic or carriers to contract with more naturopathic providers. And in that sense, if they we're willing to accept lower rates than what maybe an MD is charging for that, it could have an offset on in bringing down costs. But I wouldn't expect it to have much of a fiscal impact. And that's why I don't believe we had a fiscal impact statement for this bill.
Thank you. I appreciate your answer. But aren't we also diluting practice of medicine by physicians who went through medical school, residency, fellowships?
That's outside of
That's it,
my
right?
scope. That's for you guys to figure out and who you license and what their scope of practice is. So
Right. So I'm running on the thesis that we don't have enough primary care physicians, nurse practitioners and that we're always hearing about people having a hard time getting one. So that if we can add naturopaths into the mix, that we would be doing a benefit to our constituents.
Oh, I agree that we should use them. I just don't think that they should be reimbursed or billing at the same rate as a physician who's been practicing.
Where do you see that? Where,
We
where
don't,
do you
we
see
were,
that they
we
would?
were, so
Because
you're
that's how
thinking
billing
that we're
works.
raising them the status.
Yes.
And I would say is, we're not. That does not, what she just read to you, does not raise their status. It doesn't change their status, okay? And that, yes, that when it comes to reimbursements, the health insurance companies pay nurse practitioners less than MDs.
Okay, just to level set. So this lets patients get care at a lower care level, but the provider will get paid at the higher level than current. That's how billing works.
Okay. Do you believe nurse practitioners are lower quality than a physician?
They practice at a different scope. They are not physicians. They're mid-levels.
So, but we allow nurse practitioners to be primary care physicians. Do you
Well, they're
think
not
we are doing
physicians,
a
so we don't allow them to practice as primary care physicians.
We do.
That's an oxymoron. You don't let nurse practitioners practice as physicians. You can have a nurse practitioner who practices in primary care, but they also have to have a resource.
Right now, my primary care physician is a nurse practitioner. She is absolutely,
I'm sure she's
Absolutely.
wonderful.
no,
Yes.
I'm not asking about that because she's moving on. So I don't know who my next one is going to be. Okay, but that she is absolutely. She is my primary care physician. These on my health insurance card. She's considered my primary. The insurance companies, the pharmaceutical companies, all treat her as my primary care physician. And what we learned in testimony was that her
A nurse is never a physician,
a nurse practitioner
is
rate.
not a physician.
And where do we say naturopaths are physicians?
That's what we're calling them.
No.
No,
Well,
we're not.
We're calling them naturopathic
The,
doctors.
the payment depends on the
naturopath.
contract.
Naturopathic doctors is what
Well,
we're saying.
When you get into the semantics about the word doctor,
Well,
go back to the
I mean-
the optometrist ophthalmologist debate we had on the House floor.
it can be your not. They
They're
can
both
be your.
called doctors.
But doesn't it depend on what the insurance company would like to contract
good
with?
point.
Exactly.
She
depending
can be
on
your
their
primary
tiers?
care, but she or any nurse.
So that they may
This is
not
semantics.
cover.
Okay.
They may
So
cover.
the semantics are the important piece.
No, it
that is-
isn't.
A nurse is never a doctor.
Okay.
Period.
So Representative Miles, you're entitled to your opinion, and you can certainly share that.
gonna go ballistic
You know,
in a
but
minute.
if the vote doesn't go the way you like, you can certainly share that in a minority report. Okay. So the motion is ought to pass. Is the motion clear? Yes, Representative Spear.
Is there anything that we've said in the bill or anywhere else that says the insurance company is not allowed to negotiate with the naturopath for whatever rate the two of them agree on?
There's nothing in here that says that in this
So
legislation.
they are going to negotiate the rate and we got nothing to do with it.
As we know that it's more predetermined that the insurance company is going to tell them what they're going to reimburse. them,
Okay,
And it's
whatever
whether
it
the
is.
naturopath wants to accept it.
Okay.
Okay. Motion's clear. Okay, all those in favor, say aye. 1, 2, 3, 4, 5. Those opposed? Okay, the motion carries 5-1. All right, relative to insurance, 606, relative to insurance coverage for marker testing. Okay, so what we heard in committee is that, well, this is another Medicaid issue. And that we heard is that when it comes to using biomarkers, that is decided by the physician and then submitted for for approval. And I guess I'm a little fuzzy in how that works under Medicaid. So. Good morning.
Good morning, Mr. Chairman. My name is Jonathan Ballard. I work as the Chief Medical Officer at the Department of Health and Human Services
Right.
with
Okay.
work in Medicaid.
So what is this bill doing that you can't get now? Does Medicaid not cover biomarkers at all?
Medicaid covers some biomarkers. What this bill does is it expands and creates a definition of what a biomarker is. The department does not oppose this bill as it is currently written and amended in the Senate. This bill puts a definition, a requirement that it requires medical necessity as
Right.
determined by Medicaid. It still creates a prior authorization or review process to ensure that it's medically necessary for the particular biomarkers covered under this bill.
So if you're saying you already do cover it, what's the purpose of this bill? Why are we passing it? Or
Purpose
why
of
did
this bill, then, it allows us to establish a process and cover a medical necessity requirement. It puts some constraints on the expansion of these costs now that could be advantageous to the state financially over time. Otherwise, if there were a bill that came before you that removed medical necessity or did not have that clarified as part of the requirements for it, there are a lot of biomarker tests out there that are not been shown in evidence to be medically necessary for patients and could cause a lot of cost in the future for the state.
So you're saying you want to pass this because you want to make sure that we have the proper controls and guardrails in terms of making sure that it doesn't expand too fast and then start costing the state too much money.
I think that's accurate. The department is neutral on this bill, but is not opposed to the bill as it currently is written because of those
Covers.
safeguards that are currently in it. If you were to change anything about this bill, the department would not
Gotcha. Okay,
would oppose it.
good. Thank you. Yes. So do we have a question? Yes.
Thank you. So in my notes, I see that defining medically necessary for this particular bill and these tests are going to be defined in rules, but are not currently defined. Is that a correct statement
Medical necessity is defined in rules
for
currently,
these biomarkers?
and it is in the federal registrar, so we have to comply with federal
Yeah,
rules.
you got to comply with
This
that.
bill, as it is currently written, does not conflict with that. That's why we're concerned if you make any changes to this, it could conflict with state rules and federal requirements for our federal match.
So do you need to update any of the rules, or they're currently defined?
Currently defined,
thank you.
no changes necessary.
Thank you very much.
Okay. Is there anybody who has a different opinion about passing this bill? Okay, former Senator Bragdon. And former rep.
And former rep.
Good
point. Thank you.
Oh my God, where's your orange badge?
Wait. I have two for just such an emergency.
No,
Peter Bragdon, representing Harvard Pilgrim Healthcare. Not necessarily objecting to the bill, but just pointing out that the bill has a whole bunch of definitions that show up in the insurance statutes because the original bill in the Senate required coverage for commercial insurance as well. Now it's just Medicaid, and we would prefer that the definitions go over to Medicaid statutes as well, so we don't have some definitions sitting around in insurance statutes that get built upon.
So you don't like the definitions that are in 420J?
Right. They'd be, a better home for them would be in the Medicaid statutes with the rest of the bill. That's the only thing I wanted to point out.
167.
Yes.
Okay.
Just,
All right.
just letting you know.
Come on back.
Makes no practical difference, just not in the insurance
Well,
statutes. We benefit.
I certainly understand. And I think this is left over because the bill originally did have 420.
The department
impact.
has no objections to moving those over to the Medicaid statutes. That would be
Okay.
fine.
All right, so this bill needs an amendment. Okay. Okay. So I will have Kristen, or somebody else wants to create an amendment? Or you have the amendment already drawn up?
Well, we have an amendment that we would prefer. For the record, Jenny Horgan, Alzheimer's Association. As mentioned in our testimony, we do have concerns with some of the language that Dr. Ballard referenced regarding Medicaid making the determination on these biomarker tests and what is being actually considered or not considered. Certainly, we are happy to continue to work with the department on trying to find a path forward, but it is something that we do have big concerns about, not actually making efforts to expand people's access in the state of New Hampshire to biomarker testing.
So you don't necessarily have a problem with this bill, but the rulemaking authority they already have, don't they?
So the bill was brought forward at the request of the Alzheimer's Association, the American Cancer Society, and a number of other specialty organizations that are advocating for increased access to biomarker testing.
Okay.
In the Senate, the bill was amended with some language that specifically talks about Medicaid making the decision about what is being covered. Our position on that at the association is that kind of codifies current practice. Medicaid already determines what biomarker tests are covered.
Right.
So this wouldn't actually expand the access that we're looking, that we think
Oh, so you wanted to mandate it?
Yes.
Well,
But we do
that-
believe that there are strong guardrails in this bill, and as it was originally presented regarding clinical utility and other aspects that limit it to appropriate treatment, diagnosing, and management of a disease.
Okay, all the more reasons why I want to get rid of that 420s written in here. Okay, all right. So I duly noted
Thank you.
that you would have hope for something better. Okay. Anybody else have any more questions about this bill? But at this point, we'll work on an amendment to change the definitions and put them in the proper section of the statute. So, and what in the Health and Human Services, what is your RSA for definitions? What is the RSA for definitions? What 167? Okay, so it must be 167:1. :1 probably.
I'll look at it, but I'll have to.
Okay, so you want to send a message to Kristen?
Yeah, that's what I was just telling.
Okay, perfect. Thank you very much. Okay. Okay, moving on. All right, 607. Here we got an easy one. Anybody would like to? This is short-term policies. Any?
I move on to pass.
Okay. Representative Miles. OTP. Okay. Any discussion on this bill? Not to pass? Okay. All those in favor say aye.
Aye.
Representative Walsh? No, she's not right. Right. 1, 2, 3, 4, 5, 6. Okay. All right. Moving right along. I told you that was the easy one. Okay. 614, establishing multiple caregiver self-insured risk coverage arrangement for nonprofit, for-profit providers and services. So I'll move to pass. so I can make Senator Rashadi like me.
Is there
And
an old, it's a new title?
no, there's no new amendment to it. We're just going to pass.
In my notes, I said we need an amendment, but I didn't write down what for.
Was there a need for an amendment? Oh, again, the effective date. Well, this
So I-
one's got January 1. How can it be? You want this to go in effect right away? So
No.
you guys can start finding it?
60 days?
Oh, you
No,
want-
it's 60 days is my understanding, as Representative Patuchik just mentioned. We would seek to push that out to July 1st of 27.
Well, the copy I have here from amended by the Senate says effective date January 1, 2027.
Well, in that case, then we're asking for it to be delayed another 6 months or to
Oh,
July
you want
1st
it
of 27.
effective-
July 1st of 27.
Oh, July 1st?
Yes.
Oh, I'm sorry, I didn't hear you say July.
So that's the exchange. So I had referenced, to Representative Porcelli's point, I had referenced the fact that we might have some adjustments to the proposal that we may bring forward as an amendment. We've gone through it with a fine tooth comb, and we think that we can get at the vast majority of what we might need to address via the rulemaking process. The biggest issue is giving us a little bit more time on the implementation side. So moving the effective date out to July 1st of 27 would address that. So in exchange for not having a big complex amendment, we would just ask for that one small adjustment.
Okay, now I get it. 2027. Okay, and it doesn't have to work in any calendar year because this is setting up an insurance, a risk pool. Right? So, okay. All right, so do you get that, Kristen?
So this is a new piece of legislation.
This is new legislation. Ironically, it's our favorite subject, risk pools. But it is really what created it is the same, one of the underlying issues in this case is that this is unusual, is that these daycare centers are having trouble getting insurance. And so the risk pool is a model in which they can be able to
Maybe get it.
hopefully they can get it. But and only because they're going to be buying it as a group. So, yeah.
Is that risk pool going to be big enough to actually keep the premiums kind of lower than?
It is, that could be a question, hard question whether that'll do that. But again, the issue is that you're going to get enough people in it. You create a critical mass that some insurance company might be willing to.
Okay,
We have
But we
no
don't know if we
idea
anything
that
about
they're
it
going to
yet.
go out to bid and try to find somebody.
Representative, it's going to take time, to your point. It is going to take time for the groups to come together to pool their risk, to create a risk pool that is going to be viable for sustainable, predictable premiums, stable premiums. So as I mentioned at the outset when I testified on this, I believe last week, it's going to take some time for this to be something that is of use to the entities that are struggling to find this liability coverage. But our belief is that we've got to start that process somewhere. And so to establish the mechanism by which these groups can come together to pool their risk, once we've got the program in place, then, the department as well as the individuals who will oversee the program can get to work in spreading the word about the program. There's a provision in it that allows for these types of entities in other states to become part of this program as well. We hope that that will accelerate how quickly the program will be viable from a premium standpoint. So it's going to be a bit of a process, but we wanted to get that started now.
Can they limit liability?
Can who limit liability?
In other words, can a risk pool create caps on liability?
Sure, yeah.
Well, that would be the solution.
And I think it probably
And that
will.
would be constitutional. Some trial lawyer would take that under question. They limit the liability.
Well, if you're to do it in
I'm
state
looking at your
statute.
legal counsel.
Yeah.
so.
Come on up, Emily.
Hello, I'm Emily Doherty with the Insurance Department, the Property Casualty Legal Counsel. If I understand your question, I was interpreting your question to mean in their plan in terms of sort of viewing this as
akin to an insurance policy? Can they place limits on the insurance policy? Yes, if they're making the plan, if that is your question.
Well, I guess limited liability was that suing one of these because of abuse, which is really what I think is the problem, is that they're getting sued for abuse by an employee. Can they limit that can these policies limit that liability?
That would be separate. That would be tort reform.
Yes, that's what I'm saying. Okay, that's what I thought.
And that's been a discussion that the legislature's had for many, many years now. And there's been no consensus as to whether or not well, I guess the consensus at this point is that there shouldn't be caps because nothing has passed the legislature. But at what level and all of that, we've never gotten into that level of detail. To your point, though, I think, I keep coming back to the fact that this is going to be a process. There's going to be multiple steps in how this program is going to practically work. That's going to take time. And I think that once it gets to the point where you have enough of the entities pooling their risk to make it something that is viable, that will work, I think you very well could see a situation where the program says you're going to have coverage up to, and I'll just use round numbers, up to $1 million. And then what the entities can do at that point is seek out essentially a reinsurer who will functionally serve as an umbrella policy that will cover up to some amount over and above that. But I think that there is a more viable market to fill in between where the program's coverage would end and wherever the ultimate claim settled out to be. There'll be more of a viable market for a carrier to come in to cover that, essentially what is a reinsurance purpose, reinsurance function there.
Otherwise, just get arrested.
Okay. Thank you very much. Okay. So we will put that off until we have the amendment drawn up. Okay.
That was 614.
Yeah, that's 614. Okay, 646. Relative to mental health standards of care.
Can
Why do
someone
these bills-
remind us what this one
All
is?
these bills sound the same. Okay. Yeah. This is another Medicaid. Because yeah, it's crossing out Medicare and writing Medicaid. So who can tell me about this one?
I move
Remind
ITL.
me.
A motion. I move ITL.
Okay. Move, I think, speak to legislate. Is that second by anybody? Representative Spear? Okay. Come on up and explain this one.
So
Okay.
I believe what this bill is trying to do is to get insurance to cover services that are not generally covered by health insurance, but may be covered under Medicaid. However, the way it's written, there's a lot of concerns about that, and I think it has unintended consequences. And as written, it's just not something that we would be able to implement. So, yeah.
Okay.
Answer any questions.
The-
The first thing that it's trying to do is say that it's mandating that the coverage of mental health should essentially mirror what's in the Medicaid plan. But we already have mandates in place for mental health, and mental health are covered services. It also
For Medicaid or Medicare or for the small group market? I'm confused.
This-
Which one are we talking about here?
for all markets. So all of the
Ah.
fully insured markets, you have
Okay.
to cover mental health services.
Right.
What this bill is trying to say is that that coverage needs to align with the same benefits that Medicaid is providing. And
Right.
so I think it's either a benefit expansion in requiring stuff that health insurance does not generally cover. And in that sense, it would be a new benefit mandate and that could trigger state
Having to fund.
defrayal.
Right.
Or on the other side, we're talking about health insurance benefits and just looking at what insurance benefits would be covered. And we would then say, well, they should already be synced up. The other part of it is it's trying to align Medicaid rates with with insurance rates, and we think that would have unintended consequences. Generally speaking, Medicaid reimburses at a much lower level than health insurance, and for that reason, that could cause plans, if they were to comply with that, they would likely be in violation of federal mental health parity laws. And so, to that extent, it would be very difficult for us to enforce that law. Then there's some technical changes where they're making references. They switched it from Medicare to Medicaid, but we would not be in support of that. Medicare is the better benchmark for doing rate comparisons and not Medicaid, because Medicaid rates fluctuate based on state funding and benefits.
And I noticed that you guys were never asked to make a fiscal note on this.
I believe we did do a fiscal note, and it was indeterminable because we weren't really sure what it was trying to do, but to the extent that it
Insurance
expands
Department and-
benefits, there could be defrayal. We would need to do much more analysis that I don't believe has been done to see how the Medicaid plan compares to what insurers are already covering. And we weren't really clear what the intent of the bill was. And then we would have to do analysis to see how that would impact rates, but we wouldn't be able to enforce something that conflicts with federal law. So if the rates are lower, then there's no way insurers could pay that, because they would then be in violation of federal law. And so for all of those reasons, the fiscal note was indeterminable, but likely to be an increase.
Okay, you have a question for?
It sounds to me as though it's so vague, mental health standards of care. You know, on Tuesday, I'm fine, Thursday, no. You know, it's just, I don't understand what the standards are. Where are you
Yeah.
getting your standards?
And that's why there was a lot of questions about what was intended in this bill. And I think as written, there's a lot of unintended consequences. And I think the senator who drafted this was really looking to expand coverage to services that are covered under Medicaid but may not be covered in the commercial insurance market.
So that's the intent, you think?
I think so, but there's technical difficulties in the way it's drafted.
So you're saying we should either interim study it or kill it, but it's because it's got too many problems in its current form.
Well, I think as Michelle has mentioned, the bill needs some work for the reasons that she's highlighted. But I just want to pull back for a second and get at what I think is one of the core issues, both with this piece of legislation and the other one that you're holding until the end. And that is, there is a dispute. There is real friction between providers and carriers over the nature and definition of clinical services. I think that's one of the key issues. And one of the things that I think we'll take on as a department as a bit of a summer and fall project is bringing parties together and trying to get some clarity around that, so that when we have these discussions in the future, we can at least come to, as best as possible, some sort of common understanding as to those clinical services, and so therefore what commercial insurance is going to cover as they traditionally have covered, and what's going to be outside of that scope, and that everybody can understand what's in each of those two buckets. Like I said, I think that's a long-term conversation over a couple of months, which what makes it a good summer and fall project and helps set us up better for these types of conversations going forward, whether it be this particular piece of legislation or the other. You know, I have a great deal of sympathy for the CMHCs. That's predominantly who this bill seeks to benefit. I have a great degree of sympathy for them in the sense that they operate in some respects almost like an emergency room. When somebody comes in through their doors, they have a legal obligation to treat that person. And so it's not like a typical mental health provider in that sense. And so trying to understand how we can better support them is something certainly that I feel is worthy and is a project that my team and I will undertake.
Okay.
It's a tough one, I would think.
Okay. Jim, did you say you wanted to?
Thank you. Representative Hunt, Jim Monahan with DuPont Group. I'm here today on behalf of the
Community Behavioral Health Center, which is the 10 nonprofit mental health centers. And I do have some folks from Riverbend that can answer any clinical questions that could come up today with regard to this. Let me say that certainly think there's a need, at least for one amendment to the bill, and that is to be consistent with what you've done before. I think you might want to align the effective date with the insurance year. So it takes effect upon passage, so that would certainly be a fix that would be perhaps helpful to those. that are
That's the least of my worries.
Honestly, I don't think this is a wildly complicated issue, and both representatives from the insurance department and insurers have made a bigger deal out of this than I think it needs to be. As you observed last week, it's 5 or 7% of the folks that come to the community mental health centers have commercial insurance, and there's a misalignment between what is provided by and ordered by physicians or prescribers at the mental health center with what is covered. So we all know, I mean, the reason this bill, several pages long, but it makes an amendment to a state law that has been around for some time that seeks to create parity between what we had traditionally seen as medical care and mental health care. So there's a structure here that works. What doesn't work is, and this is why Senator Rochford had titled the bill relative to standards of care. If we're going to have parity between traditional medical care and mental health care, there needs to be a standard by which we judge it by. And what we're trying to do with this legislation is just simply point out that the Medicare standard doesn't align well with what we're trying to do with caring for people with mental illness in New Hampshire, and frankly, for the care that, I as an employer and other employers purchase when we purchase commercial health coverage for mental health. So I know that you talked a few minutes ago about the state law around parity. This just tries to make that work better for everybody by establishing the right standards of care. You did the issue of just a couple of observations on some of the testimony from the insurance department is they've had this bill for months, and to come forward and say, well, we don't know what the Medicaid coverage plan looks like is a little shocking to me. Their offices are about 500 feet from the Department of Health and Human Services. In fact, over the summer, I emailed the department what is covered under the Medicaid codes when it comes to these medically necessary care. So I appreciate the commissioner's observation that we can probably find a way to work on this. I'm just hoping that we have partners on the other side that are trying to get the yes on this. And then with regard to the challenges around implementing it, I know some of the folks from the insurance maybe told me I don't understand this. I'm not capable of understanding how complex it is. But from what I've heard today, I'm not sure that it necessarily is. We were careful in drafting this with Senator Rochford so that we didn't run afoul of the federal requirements or the federal requirements on parity, that if we use the Medicaid standard instead of the Medicare standard, that it would not be in alignment. This does not force the reimbursement rate down to the Medicaid level, because if you can read, I think it's on page 2, current law addresses the fact that reimbursements would, on average, be equal to or greater than Medicaid. So we wouldn't end up in a position where we're not in parity, which is what required under the federal law, because this doesn't set a certain rate. It's aspirational, but you can go greater than the Medicaid rate. So that, and then one thing I guess I don't fully understand, I've heard a lot of people talk about defrailment, but as I understand it, if there was some suggestion that the fiscal note here is wrong and that mental health coverage is not already required, treatment is not already required by commercial insurers, then someone in the commercial insurance industry would have to file a lawsuit against the state, I presume. I presume the insurance department would defend the actions of the legislature, but I honestly don't think it would come to that, because I think that the insurers really do want to be responsive. They really do want to cover mental health services. We just need the proper standard that everybody can agree to in the contracting, and that's what this legislation does.
Wasn't this the functional support that I learned about?
Yes, and Dr. Asbury, I think, appreciated the back and forth with you. So
Yeah.
where we're looking for alignment on that is that when it comes to medically necessary rehabilitative treatments, in some instances, functional supports fall into that category, and they are prescribed by a doctor.
Right, but I asked the question, is there a potential that somebody would be on this forever? And the answer was yes. that
Like
is a
heart
possibility.
medication or dialysis.
But those are medication, those are, controlled. This is, I guess you're gonna be
Well,
using an
I-
occupational therapist for the rest of your life.
Well,
Right?
I would hope
mean,
that I
who-
wouldn't.
Who would perform some of these functions? So
They would- they-
in my,
just like-
in my mind, I would really like to interim study this bill.
Well,
Uh,
there's already a motion on the table for
I know
ITL,
there
and
is.
it was
It's
seconded.
Okay,
And
that's
Ms.
fine. That's your opinion. Can I just have my opinion?
Yes, but I just want to remind everyone what the testimony was from Ms. Heaton, which is this is unenforceable, has unintended consequences, and it can't be implemented by the DOI as written.
Okay. So my personal opinion, for whatever it's worth, is that I just heard from the insurance department that they want to work on this going forward. And I would like to be able to get an update on it in September and see how they're making progress on getting this resolved. So my personal feeling is I would rather interim study it, but the pending motion is an expedient to legislate.
And I appreciate that you heard additional information from the Commissioner of Insurance after the motion was made. I don't think this is the final executive session. I'm happy to work
No.
with the Commissioner and the department to help you understand all the issues that are before you as action bill.
My biggest issue right in my mind is whenever I see scratching out Medicare and put in Medicaid, I'm in a panic mode in terms of what the cost would be.
And I know the Medicaid issues are relatively new, perhaps, to this committee.
It's
you know,
evidently, it's,
we feel like we got to the playoffs when we got this issue to the Commerce Committee. So we'll continue to try to work with you. But
Okay.
honestly, I don't think, if you look at it through the lens of what's medically necessary, which is a standard we've created here,
Right.
it's really not that different.
but the problem with medical necessary is that evidently it changes based upon what is the insurance that is being claimed under. The insurance, evidently the
No,
difference
well,
between Medicare
certainly
and Medicaid.
the lack of reimbursement changes, but as you know, the community mental health centers are required to provide this care. And if the insurers don't pay for it, you can't, ultimately the state ends up paying for it through the the
Right.
reimbursement through Medicaid.
Or the
We're-
state decides that they don't want to, the carrier, the provider doesn't bill insurance companies and then says, oh, we want you to go hit up this unique little assessment system we have, tax system that we have,
This is not,
tax health insurance.
this tries to avoid putting ourselves in a position where we have to say, look, it's not working, we need to address it through assessment. So I know both issues are before you, but
Yeah.
assessment is not in.
Not
this bill.
yet.
Well,
Yeah, so, any rate,
I certainly support 498 because I think the system has failed, and assessment is probably a necessity there. But on 646, I think we can continue to work with the department and the insurers to get to yes.
okay, great. Is there anybody else who'd like to weigh in? Okay, Paula Rogers and then whoever's in the back there. Actually, why don't you, the one in the back, come on, why don't you come first? Because Paula's willing to wait.
Hi, my name is Kelsey Belanger, and I work for Riverbend at the Community Support Program in our adult program. So just a couple things I wanted to point out as far as talking points go is for the community mental health centers, for someone to be eligible for CSP level of care and get FSS and case management services, we do have to follow the HEM 401 criteria of eligibility that is set out for the state of New Hampshire. So
So this is a little awkward. Technically, we don't take testimony in a subcommittee. So what we're trying to do is try to get what the language of the bill resolved. Is there something in this bill, in terms of you want to point out the language in this bill, or what, in terms of why
okay.
why we should pass it in its current form?
So as far as private insurances is concerned about paying for case management and functional support, like I said, you need to be found eligible for our services. So not everyone who shows up to our door is eligible, nor would private insurance companies actually be expected to pay for case management functional support. It's not going to be a widespread thing,
As we
like
know,
you
they
guys
might
said.
not have those codes yet.
Okay.
That's what we've learned. But we learned that we're hoping that with the other bill, we hope that we can get that issue resolved.
Right. And for folks who aren't eligible for Medicaid, who do have private insurance, that limits them getting the services that they do need out in the community to help them get back to some sort of recovery.
Okay. Does anybody have any questions for her?
I just have one question for actually the chair.
Okay, well then, we're all
okay.
set with her then.
Okay.
Okay, thank you very much. Yes.
So my question is, can't the DOI work on this just without going to interim study? Like, shouldn't they be working on it anyway?
They are. They did offer to do that, right?
Yeah.
So you're making the argument of why we should just kill it.
Well, I'm just
Yeah.
posing the question,
Okay.
yeah.
Okay.
So I do have a process question. So, okay, so the department said that they would work on creating standards over the summer, get the parties together. So the outcome could be an amended version of the bill if they choose.
Well, the outcome.
Or it's not workable at
right.
all and we
Well, they
have
would
to.
be working on something for legislation for next year. So, because
So-
this point, this bill, if you kill it or interim study it, the bill in it is a goner.
Right,
Yeah.
so that's why procedurally, I'm just wondering, do we start fresh all right, so if we ITL it, we have to start fresh with a new bill.
Right.
If we interim study it,
At
do
least we get to
amend
talk
it?
about it. We get to talk about it in September. We remind ourselves to talk about it and
But
get
to
an
what,
update.
I'm just not
from
sure
the
to what
insurance department.
purpose.
That's true. We don't have to do that, especially when it's election time.
No,
too.
I'm just really.
People don't want to
I
be
always-
bothered by
I'm
coming in.
always
and-
curious as to the reason for the.
Yeah, I myself like to work on, when issues that are putting off the next year, and the department is talking about working on it, I like to get an update. And
This
and
would-
that-
that's
and-
the
and
mechanism
interim
to
study
get-
is that. But that in terms of just killing it outright, that's fine too.
But if we kill it outright, will the department still work on it or?
Yeah.
Yes,
Oh.
they're committed to doing it, no matter
Oh.
what.
All right, thank you.
Okay. All right. Who else would like to speak?
Good morning, Mr. Chairman, members of the committee.
Yes.
Sabrina Dunlap, Anthem. I guess I just wanted to express the fact that I've listened to a lot of discussion around the sort of abrasion between Medicaid and commercial insurer coverage. And it came up and it's been building for a few years, apparently. And each side is fully invested in trying to make their case before the policymakers. We're not the only state dealing with this. And so it might be helpful if there were an interim study disposition of both the bills, 498 as well as this one, so that you could get a sense of what other states are doing. And so rather than talking about the abrasion and trying to force one payment mechanism to echo the other and take away all of this fuss that we're in about the bills, you might find other states are trying to align to smooth the edges because they're very different payment delivery mechanisms and they have a very different history. And one could mention a single payer system and we could, I guess, take care of the whole issue, couldn't we? And everybody will shake their head. So I guess the best thing to consider is how do we gracefully deal with what has gotten to be kind of an unpleasant atmosphere around these bills. And so my sense would be, and I would hope you'd consider not killing them, but interim study, because it's not going to go away. So one of my plans certainly wants to add something.
Just because I'm on the ground working directly with the CMHCs. I just want to clarify that we haven't seen a bill like this in any other state that is essentially trying to turn commercial insurance into Medicaid. And when this bill first came up, it was presented as sort of a discussion starter. And I noted we don't need a bill to have discussions, but nevertheless, we've had in-depth conversations with the Community Behavioral Health Association. And what we have discovered is that it comes down to 2 codes around functional support services. We actually do cover those in some of our contracts with CMHCs, not all of them, but that is certainly something we could work through in a contract. And I think that it's just historically, commercial insurance has not covered the exact same thing as Medicaid. And that's what I tried to explain in my testimony in the hearing, is that we are not exactly the same. We're very close, but we also do oftentimes work out arrangements where we actually cover those functional support services, like peer-to-peer services, but they're not a standalone billable item. They're part of a code that covers multiple services. So I just think the way the bill is drafted is extremely problematic. We would be in favor of an ITL motion on this one. The conversations will continue. We're always at the table with the insurance department working through these issues, but I think the way it's drafted, it's very problematic. Thank you.
Okay.
One just last thing. I just thought about the other 2 bills that talk about Medicaid versus commercial insurers that you've talked about that are sort of low-key, biomarkers and GLP. So that tension is in the system, and we just need to address it in a more
That's for sure.
productive
For
fashion.
this year, this
Thank
was
you.
a watershed event. Okay. All right, so the motion is inexpedient to legislate. Any discussion on the motion? All those in favor say aye. 1, 2, 3, 4, 5, 6. Okay.
646 is RTL.
Can I just say I'm thrilled that I agree with Anthem?
Duly noted. Okay. All right, next is 647, authorizing Department of Insurance to participate in a cooperative procurement group via an intercontinental agreement for a prescription drug discount program. Okay, I'll move inexpedient to legislate.
Yeah, why?
I'll tell you. I'm writing my name down. Okay. The reason why I'm opposed to this bill is, first of all, that I think giving it to the insurance department is a conflict of interest to the insurance department. Giving it to the insurance department is a conflict. Where it sits and who administrates it. Okay. So they need to find another administrator. So if you want to interim study it, to find somebody else to implement it. But the number one reason why I'm opposed to this bill is that we've already been down this path about coupons.
Oh, yeah.
Okay. And we know that, yes, the GoodRx has coupons, has discounts. Okay. But the reality is they're only on name brand products. There's nothing generic about them. And they are, and what the whole point is that yes, they're the pharmaceutical companies, okay, make these things available because they want you to say, oh, I love that name brand product. And when when the coupons run out, they get upset that the coupon's not available anymore, and then have to buy the higher price.
Except that
product.
in this particular program, it's not for just name brands, it's for everything.
That's what they'll tell you, but the reality is
Oh.
the coupons are only name brand.
So they really won't cover the generics, even
Yeah.
though they say they do.
But if we save anybody some money, isn't that a good thing?
Well, the problem is it distorts health insurance copays and deductibles. And in particular, I know this is not so much in the small group market, but it's a big effect in the ERISA plans. And that is that ERISA's cost-sharing plan with the employee is built into whether it's generic or and those copays. So if all those ERISA employees start running off and trying to get the coupons, now the ERISA is their math was screwed up, and when those coupons run out, then they're going to have a huge problem in terms of balancing their billing. So at this point, the only thing this program offers that's different than GoodRx is that it has privacy.
But it's easy, and all they have to do is
No, we have
we
to
have to
fund it.
enable it. No,
No.
we don't have to fund it.
Yes, we have to fund it.
No, 3 out of the 6 states that are doing it did not fund it.
No, they put it under their controller departments. They found somebody in there who was willing to take on the task. So if you want to, interim study this bill, and let's find somebody who, but clearly for the insurance department, I think it's a total conflict for insurance, so it should not be in. But if you want to do like these other states did, you've got to find some state entity who is willing to take it on without asking for more money.
I think for the consumers, if we can save them any bit of money at any point in the process, that's what we should do.
We did a really big thing last year to get out from under coupons. If this thing is really and truly based on coupons, then it's dead as far as I'm concerned.
I'm willing to, interim study it if you guys would rather do that and to find another state agency.
Yes.
Okay. Interim study. Okay. And you want to move that, Representative, or you want me to move it?
I can move it.
Okay, Representative Miles moves interim study. I'll second the motion. Any discussion on interim study? Because we're going to try to find another department who will do it for no cost.
But what about the idea that it's based on coupons? We fought that battle really hard last time.
That's true too.
I mean, I think we almost came to blows.
Yeah, right. So, yeah.
Subject to the approval of the governor and the executive council is what it says here in the bill.
Right.
That's right.
So,
what?
do you not like interim study?
Because
Okay.
unless there's a specific action item, other than it'll just sit around and then we'll kill it in September, I just,
Okay, so you're opposed to the interim study motion? Okay. Well, why don't we start with,
But we're just kicking this down
Kick it down the road.
for 3 months.
well, again, I don't oppose interim study because it's kicking, yes, it's kicking, but it keeps it around and forces us to talk about it again in September, which
Somebody has an action item to shop it to another department.
at this, in terms of the
Why we're interim studying it is because we're trying to find
what government agency should be doing it.
that would right.
Right.
Okay.
That-
And who is going to,
Shopping around, Representative Miles she's gonna go find somebody. Yeah, she's, right, well,
zero funding, with zero funding.
evidently,
That's right.
yeah, evidently zero funding, she gets it. If he's gonna find some department that just have got all the time in the world to take this program on. What's that? Fishing game, right? Okay. Okay, so the motion is interim study. Is the question clear? All those in favor say yes. 1, 2, 3, 4, 5, 6. Okay. Okay, risk pool we're holding on to, 665, relative to pharmacy benefit manager, benefit care laws, notice of drug pricing options, pharmacy benefit manager practice. Okay, so I know there's one part of this bill I really don't like. That's the last one. So I did ask the insurance department, is there anything in here that they want to salvage? Anything in here that salvage? Just for the record and for those people who are in the audience,
On what number are we on?
this is 665. I hold sometimes it feels like a unique position, but that because sometimes people they glaze over when I say it, is that right now this idea of licensure, the rule of licensure, the idea of licensure of PBMs makes no sense at all to me because PBMs are a subcontractor of a health insurance company. 665. Okay, 681 is on hold. But the one thing I care most about, my number one issue, is as we talked about the minimum loss ratio, is that I worry about the rebates and coupons and everything that goes on between PBMs. I want to make sure that those numbers are included in the MLR, so that, you know, there's no funny money deals going on the side. So otherwise, all this other stuff about PBMs, if I had my way, I would just repeal the PBM licensure altogether, because I know it was passed, it was a feel-good measure that was passed that somehow thought we were going to rein in PBMs or have more control over it. So that's why I'm asking the insurance department to say whether that's true or not.
So I'm not sure what you're thinking, but I think that the language in this bill at this point has been so mashed up between all the bills relating to PBMs that I think I would be willing to ITL this, because I think we could just start
Okay.
over.
Hold that thought.
Okay.
Okay.
So we helped draft an initial amendment to this bill, taking some of the concepts that Senator Rochefort wanted to move forward with
Right.
and putting them, there was a number of competing bills in the Senate, and we helped kind of come up with something that would be workable. And then it was amended further, I believe, on the floor to add in some more amendments.
Something that,
My understanding
amendment,
is that
yeah.
I think there could be some consensus on some of these things, but it would need some additional work. But I think there is room to negotiate maybe with the stakeholders and get something that, you know, most people would be okay with. But we haven't done that yet, because we're going to take your lead and find out like what is it that you want to do. And so our that's the approach we took when we were drafting the initial amendment, is trying to put onto paper some of the concepts in a way that would actually make them work, and is in a way that the department would be able to enforce them. So if you want to interim study it, go ahead. If you want us to work further on it, let us know what, you know, the parameters are, and we're happy to work with the stakeholders. But I
or
think
if we want
need
to kill
some-
it, there-
it's up to you guys. I mean, there's oftentimes a lot of PBM legislation out there. This does make some amendments to clean up some of that stuff, to put more requirements in place around documentation and reporting requirements. So
but
there's,
does it help you in terms of the regulating?
yes,
PBMs.
there's a good amount of what's in this bill that would actually strengthen our ability to regulate that, these types of entities and prescription drugs, and put in more record-keeping requirements so that it'll make our jobs a little bit easier. So we're definitely in support of those provisions.
Right. So, but each one of those needs work at this point, and we're not going to get it done in next week.
I think we could, if there was, if that's where you guys wanted to move. If there's no support for it in its current state,
So
and
which
it's nowhere near
one do you
close,
which
then-
one do you think is workable? Or
I
that you
believe
would-
that there were, I would say, 2 to 4 areas that were somewhat contentious. I think it was the fine amount, the fiduciary duty, and I think industry had some suggestions for how to fix that. And I'm blanking, where's Cam on the other two? What were the other two? The steering, which was added on in one of the amendments that was not part of what we drafted initially. And is that everything?
No, the steering. You're talking about the steering one is the last.
Oh.
No, I want the last thing gone. And I've already told the senator that I wasn't interested in that. Is that what you're talking about? Steering? Was the one
Yeah.
about the pharmacist having to tell you?
No,
No,
it's
okay.
where
Okay.
the section about where you couldn't give an incentive to go to pharmacies that have a relationship with
Oh, okay. Steering to
steering to lower cost
PBM,
options. And we think
a
that,
PBM.
yeah, I
owned-
think there
oh,
could be some unintended consequences.
Yeah, that
with
would be ugly.
so.
We wouldn't want that.
So, I mean, I think there's good portions of the bill that there is some consensus around. So I think there is, there could be some work done to try to get to more of a consensus on those 4 issues that are outstanding. And if you guys give us some direction about where you're leaning on those, you know, we can
Well,
work
like I
on
say, I have no
addressing
direction because I would just repeal the whole statute. So at this point, I would say to you, if we hold off for a week, And because next week, I want to exec everything out next week. I don't want to wait till the last week. I got too much help from the
Mr.
house-
Chairman, a
the clerk
potential-
for that. So I-
Potential solution for you. So what we can do is take the week that you've referenced, bring the stakeholders back together, isolate the 4 issues that are controversial, see what we can do with those, try to get as much consensus and compromise around those 4 issues as we can. If we can, then they can go forward with the remainder of the bill that is not contentious. And if not, we could just remove those sections where there's not consensus.
So what is
that's
not
been reached.
contentious in here?
Pretty much everything else.
Yeah.
It makes, there's a
title.
lot of changes in this bill. Some of it's about the data reporting and the requirements around that. I think other than maybe it being semi-annually versus annually, there was a little bit of non-consensus. But even if we made it annually, I think everyone's on board with that data reporting. I think fixing some of the definitions and expanding some of the definitions, I don't think, based on the testimony from the hearing, it seemed like there was consensus on making all of those changes. So I think even, like the commissioner said, if we just remove the stuff that there's not consensus on, there's still a good amount that we would be able to move forward on, I think.
We brought the stakeholders together prior to the bill going to the Senate floor, and at that time, there were 2 to 2.5 issues that were identified. Then it hit the Senate floor, there were some floor amendments, and that expanded
It's
to
got
4.
14 sections in this bill.
It's a big statute, Mr. Chairman.
Can we
The
just
PBM
move
statute's a
ITL?
big statute?
What's that?
The PBM statute is
It's a
big?
big statute.
Oh, boy, I'd love
it
to repeal
amends-
that now.
It amends the PBM statute as well as the managed care law, which is
Right.
Okay,
120J.
it's all right.
So
Some
of it is related to prescription drugs. Some of it is related to PBM.
Okay.
Can we just move
I just-
ITL? This is a
No,
mess.
wait a minute.
It's a mess.
We're paying these people to work. They're sitting
plenty
and
to
telling
do.
us, they're sitting and telling us, hey, we've got some things that would help,
Okay.
okay?
All right.
I'm not going to kill that.
There
I'm
you
not
go.
going to vote for it anyway.
Well, no.
So we could,
Okay.
so we would be
So
postponing
at this point,
a week.
I'm going to put it on hold till next week.
And then what, I just want to understand, so next week, we would see a potential amendment
So
for
next
only
week,
the
yes.
sections that we have consensus on. So this could turn, this will turn into
Whatever
very
they,
specific, targeted, agreed to items.
Right. exactly.
And then we would be looking at that amendment.
Exactly.
and Gutting all of this.
That's correct.
Okay, I'm good.
I wouldn't say it's a gutting. I think there's really the 4 things are 4
Refinement.
small.
It's
Well,
refined.
you'll be
Refining.
taking out
yeah.
what's good.
I
and
wouldn't
putting
focus
it
on the
in
length. of
So
it.
the amendment would be a replace all with these items that you would be looking for.
Yeah, and having, you know what I'm saying, having saying this, that if we get there and if there are people in the audience who are going to come up and, Curtis comes up and say, wait, they're start waving the red flag in terms of some of these issues, then at that point,
We kill it.
we could kill it.
Okay, I'm good. Thank you.
Okay, but I'm willing to, as much as I think the whole statute, pharmaceutical benefit manager legislation law is nonsensical, I'm more than willing to work on refining it if it helps the department to calculate those minimum loss ratios. So, okay.
Thanks to the DOI and the DHHS for all the work.
Okay, now back to 498. Are you ready to vote on it, or do you want to put it off for a week?
Hold it.
We can put it off for a week. Okay. Because I haven't gotten any texts from anybody.
So what is the issue that we're putting this off for a week in order to, somebody,
Well, my feeling is that we should be interim studying the bill, so that we can keep an eye on making sure that that come September, that the contracts are done. That's my expectation is that we will have contracts between NFI and Anthem.
okay, but what are we doing between now? What is the action item between now and next week?
Nothing for us. It's the
That Anthem hopefully gets codes to NFI. That's
Right.
my
Well, I'm saying we
understanding.
will mandate that if come September if there's a problem. But we want to hear that from the company that they're okay and they can move forward. But in terms of the bill in its current form with the assessment system, there is no way that makes any sense, that assessment system. It's just, it flies on the face of everything we do in insurance. It's a horrible camel's nose under the tent, because at that point, you take that other bill, the other we just had, the Medicare, Medicaid thing, and say, oh yeah, let's just have the assessment pay for that too. It
So
would open
I
a
have
huge
big
can of worms.
problem with the assessment. So then what do we, again, procedurally, what would happen?
We're hoping that this problem can be resolved without that assessment system.
Okay. So
That
if
is our-
the
that is
codes
our
are
goal.
all worked out, then we don't need the bill, basically?
At that point, only reason I would interim study is because I want to know that come September, we can do a follow-up to see what exactly has occurred. And, whether, all the parties are moving forward, and if there is need for legislation to mandate the codes.
Well, essentially, in my opinion, the people of the state of New Hampshire have been paying for things that people who have insurance, such as Anthem and maybe others, could have been paying.
Yeah, but they were never billed.
They're never billed because they can't bill them.
No,
because they don't have
they never
codes.
tried. They never tried to bill them. And
Can we
the
hear-
executive
Can
council
we hear from DHS?
Can we hear from the
expectation was,
person?
the executive council's expectation was that they would do the billing.
I understand that. Would it be appropriate if the person from NFI could,
If you
make
want
a
him to come on up,
if he would? Thank you, Mr. Chair.
my pleasure. So what is your question?
My question is, have you been billing Anthem, and if not, why?
We have not
Or
been,
Or not just Anthem, maybe other
Well,
insurance?
originally, the contract negotiations was between NFI, and, reason why we haven't seen this bill or issue in the last 2 years was the expectation that Anthem and NFI would have come to an agreement.
okay, for the record, Luke Renard, Executive Director, NFI North. We haven't billed Anthem or any other insurer yet, per our contract, which is standard language, that we would bill available services to commercial insurance. The circular, kind of illogical part is there's no existing code. So there's no mechanism for us to send them an invoice. There is no code to bill against right now. And I mean, even Sabrina recognized there is no current code right now. So that's kind of the hiccup in this system.
So I just came up to join Luke. For the record, Jenny O'Higgins, Legislative Liaison for Behavioral Health at DHHS. Just because the contract that's being referenced, the language within that contract is standard language in our contracts that says that the department will be the payer of last resort. So the way that that's written in that section that I believe is being referenced today would be in each contract. So another example would be like the doorway services. We would put in there that the doorways would need to bill any clinical services that are billable, and then the state opioid response grant would fund those other services. So it works in a similar way. It's standard contract language. There's not some specific call out in this contract that says that NFI must become in contract with the carriers. It's just the standard language that the state should always be the payer of last resort. So if these services were billable, we'd expect them to be billed first, but they haven't been billable.
Okay, so basically, the issue has been, how long has this been that they've never had these codes? I mean, when was the first time you took on a fully insured kid? 4 years ago?
Yeah, probably
4 years, this
2021.
issue's been around 4 years, and it's always, oh, there's no code, there's no code?
There
Or when-
are Medicaid codes, and there's the conversations that have been ongoing where they have been shared. But there isn't, these services are not currently billable under commercial insurance.
Because you think there is no code to bill it under. And I'm saying is, so you're going to make this argument that we want to use this assessment system because over this last 4 years, you've been covering these kids with the last resort and never, ever came to the legislature and say, gee, we're having a problem upholding what the executive council thought they were agreeing to, which is that private insurance would be billed. And you never came to us and never said to us, you need to mandate that they have a building code.
So there has been legislation every year.
Yeah, that's what I heard. It's been in the Senate and died in the Senate.
And came to the legislature to ask the money that went into that contract that you're seeing that the executive council passed that you're referencing, that was in the budget. So that money went before the legislature through the budget process in order to say there's a gap in services that commercial insurers are not paying for this service. And the money was put into the budget to cover that gap through the legislative budget.
So therefore, you're saying the legislature was okay with making these payments?
Covering a gap in the services with the
I wouldn't call it a gap. You're saying we were fully willing to pay for fully insured kids.
Well, in order to get kids, I mean, these are discussions that are ongoing from trying to reduce psychiatric hospitalization and inpatient care that is more costly.
That was the patient zero.
Mission Zero,
Mission
yes,
Zero.
and reducing the ED boarding. And then those legislative efforts started in 2022 to try to address this. And there is a commission report, and you'll see throughout the bills and the commission reports and the meeting minutes on these issues, the conversations with private, commercial insurers and the CMEs has been ongoing for that amount of time, with the idea that we are all aware of the issue and these
No, I was
services
never
should
aware. This
be
committee was never aware of this problem.
involved.
Was never brought to our attention. And we're here a lot.
I was just referencing the
We're,
CMEs.
we're,
and
we're
the
usually
private
easy to
commercial
find. I mean,
carriers.
I don't even screen my phone calls.
I was just referencing the commercial carriers and CMEs in the conversation with the
Right.
department has been ongoing for
Okay.
years, with the same issue and
Right.
publicly available information on the issue.
Right.
So.
So at the end of the day, if we interim study this bill and keep it in come September, if you can't get an agreement, you can't get it done, you can't have it solved, there's some, then we will pass legislation next year to mandate it. Or we could write legislation
Can I ask a question?
pending, write something, but yes, okay,
Is it possible, since you're giving us a week, thank you,
yes.
that we work on an amendment to this so that it's not assessments? And it's an amendment
The amendment
that-
to say, to
to
have,
say,
mandate the insurance
please
companies
bill,
have to,
right,
have to,
please bill
I
the
guess,
commercial insurance when available through the patient.
Sure.
So,
It would, the commercial insurance though would have to be available with that language. So
That's
that's
correct.
been the
You
problem
need to,
along the way.
you need to
Right.
sit down with the insurance companies and come up with an amendment that says that you get reimbursed for it.
isn't that what we're working towards? Or are you looking for something
So-
else?
Well, no, it's just that those have been those ongoing conversations for multiple years. Have been
Okay,
the-
so
the
by
I know, but to
But
his
we don't-
point,
we
this
don't-
is who
here's the
handles
point.
insurance.
We don't
and we've
know
never heard
what's
it.
been going on. All we know is that this legislation has been coming to the Senate for the last 3 years, 4 years, and always died in the Senate. And then you come to us and say, "Oh my God, this is an emergency. This got to happen. The sky's falling." And we go, "Wait a second now.
You're right. I
We
agree with that.
this committee works very hard, and you sat through today, so you can see how we work very hard to try to make legislation work and solve problems for the state. So give us a chance to do this one right. But on the end of the day, I do have two fundamental problems with your bill. One is that the assessment system, and two is the idea that that we have a Medicaid organization, a Medicaid contract that we're forcing private insurance companies, to be a part of, which to me that defeats the whole purpose of why we invented managed care. we created it because we wanted those contracts. We wanted the contracts to be issued, and we want negotiated, we want that relationship. We realize there's some friction there, but to come back and say, throw your hands up and say, oh, well, we were not even gonna wanna work that out. No, welcome to Commerce. I know you've been over in finance, I guess. I don't know what other committees you've been doing, but in Commerce, we like it to be worked out.
Yeah, no, I so appreciate that. I mean, we're happy to be here and to get it right, for sure. The program was created out of the Children's System of Care, though, which is a broader program that's all of us. This is for New Hampshire kids. So it's not like it came, out
Yeah.
of just this should be a Medicaid program only. It's for kids involved in multiple
I
systems.
love you saying that to me, because well, you know what that says to me is, then having the state paying for it makes perfect sense. If this is a benefit that we, the state, have decided to give to everyone who is between 3 and 21 and who has severe mental care needs. Okay, so that's a state program. So that means you shouldn't even be worrying about private insurance. That is something that we, the state of New Hampshire, thought this is a wonderful program, a great idea, and that we should be paying 100% of the cost.
I just want to make sure I think you're misinterpreting that in some way, just to clarify a little bit that everything across the children's system of care, if we were unable to bill for all care of outpatient care of kids, residential care of kids who have commercial insurance, that would be very problematic. So when we say like, we, the state, I mean, we're looking at all kids, right? Like our mission as DHHS is the health and well-being of all of our residents. So we
Right.
don't look at people by their insurance carrier when we try to solve problems.
Well, the whole bill here is about their insurance carrier.
Initially, when we're trying to solve problems, we're not looking at whether or not a person should be, the eligibility criteria is not insurance-based.
right.
Instead, the eligibility criteria is needs-based. What
Correct.
is the needs of the person in front of us? Then on the back end, we have to figure out what are all the ways that the state can and will pay for this. So I just want to be clear, I think across the whole children's system of care, there are many other types of billable services. So it wasn't created as some sort of carve out.
Either the state owns it or it doesn't. If we own it, then we pay for it. Don't go looking for somebody else to pay for it.
We're just looking for their current
That
coverage.
again, I'm separating this from insurance, insurance payments. I understand the system is set up that Medicaid is insurance-like, okay? But as we just had with all these other bills, that Medicaid is definitely different than private insurance, okay? And may the two never meet.
Okay. What would you like us to do in the week time?
I
that
want
you're
you to
asking for? So we can be clear on that.
to make Representative Walz happy, okay? I want you to sit down with the insurers and work out the codes. I want to hear that the codes exist. I want to hear that you will now feel comfortable to build them.
On Tuesday.
Technically, you need to have it done by Monday so I can get the amendment drawn up and have it ready for Tuesday.
On Monday.
Yes.
Well, for the record, I agree with everything that the chairman has said. So, now, I mean, I'm just seconding it that, we haven't seen this ever, and he's the expert on that. He's been here a few years, so he would know. So
Okay.
if you want a
All right.
solution, then it's
I'm
in
gonna
your
let
hand.
you go
No, I
because
think we're
you have
very
your work
glad
cut
to
out
have
for
you.
you.
Yeah. Thanks.
So again, we're just looking at this little tiny slice here, right? On
Yeah.
the chart that you provided and all
Yeah.
the additional
Yeah,
documentation.
they're
So I want to
claiming,
make sure that we have a very clear action item for next week. Is
Yeah.
the action.
the action, but the action is that they'll have a code, I guess the codes. We get it worked out.
And then the little slice that's in question goes away.
Exactly.
Okay, go.
Have a wonderful rest of the week and good weekend. See you on Tuesday. Yes.
I have a technical question.
Yes, you can come up. Yeah, you had a question for them or?
No, I have a technical question to you.
Okay.
So I keep hearing it hasn't been brought to the legislature, but didn't we also hear that it was in the budget last year?
The dollar amounts, they have been paid by the state. Yeah, we've been paying for it all along. And here's the irony. Nobody ever said, gee, why aren't you billing the private insurance companies? Nobody ever asked that question.
Thank you, Mr. Chair. Sabrina Dunlap with Anthem. I just wanted to clarify a couple things that I think have gotten a little fuzzy around the timing. I've been with Anthem for 6 years. The first I learned about this issue was spring of 2024 on a different mental health bill. I did have conversations with both CMEs. We have a very cordial relationship. What came out of those discussions was they said, we do not have enough volume of kids with commercial insurance for it to make sense for us to come into network with you. It was not until fall of 2025 when I was able to be in a meeting with several stakeholders, including Deputy Commissioner Henn, when I pointed out that the CMEs are not in our networks. And so this idea that we're not paying, I said, well, could we work on getting them in our network?
CMEs are,
Sorry, NFI North and Connected Families, New Hampshire.
okay.
So the time frame is quite short, actually, because it was from that meeting in the fall when we finally got numbers from DHHS that we had any of our members going to the CMEs. Until that point, we had no data. We did not know if our members were actually getting care there because they don't bill us and we don't have contracts with them. So the time frame is actually quite short. Since December, my team has been working diligently with NFI North because we were instructed because they have the most volume, we're the biggest carrier, it makes sense for us to work together. We have been. I will say it's difficult to try to negotiate contracts when you have state agencies involved and other parties involved who are not at the table negotiating. It's made it difficult. I just talked to Luke from NFI North. I think we are making progress. I stand before you today saying I am committed in good faith to figure something out. So I just wanted to be clear about the time frame there and be clear about the fact that we, and I know the other carriers are too, are committed to figuring something out. So thank you for the opportunity to speak. Happy
And
to
how
take
many
questions.
kids
Any
are we
question?
talking about? I'm sorry.
Yep, yes, go ahead. Representative.
So I read some of the information that you sent. How many, we have to, I fully support covering kids with these horrible problems, fully support it. We need to do something. But how many kids do you think would be impacted by the commercial insurance payments?
Thank you for that question. It's not entirely clear to me how many of our members are currently at the CMEs. I think it's somewhere between 35 and 50 based on what DHHS sent to us, I think. I don't know for sure. And I just want to say that we do cover a broad range of mental health services. So it's not like it's just fast forward and there's nothing else. And I totally appreciate and understand that if we have members going there, we would like to figure out a way to have a contract and reimburse for those services. So that is really what we're working on. It's not a huge number of kids, which is not to take away from the importance, but it is to say, I know we can figure this out. It's not a huge number of kids.
Just a quick
Well,
follow-up.
I can actually
So by
answer that
next-
question.
Yes, sir.
Yes. So based on the fiscal note, the bill was asking for $2.5 million.
Mhm.
Based on the conversations I had, the cost is $50,000 per kid. The nice thing about this, it's actually capped. There's actually, the kid's only in the program for 18 months. And, so there is not an open-ended like the other Medicaid bills we've seen, okay? And so if you multiply 50,000 and or divide 50,000 to 2.5 million, you come up with 50 kids.
And growing. But I just wanted
Well, that's the
to-
whole thing, is that
and
you could
growing.
say that if you were to pass this legislation, then the word would get out that private kids are in. And now, because most of the phone calls I got from people who had private insurance, they were always the assumption that this program was not available for them. And that, well, we were passing legislation to make it available for them. So, today it's 2.5 million. Who knows what it'd be once the word got out that private school kids could be
Or
in the program.
there's, additional issues that we have to deal with. But I just want to make sure, for next week, Sabrina, what do you think you could tell us? I mean, what action items do you think that you would be able to just give us a status on where you are, what the issues are, and what the next steps would be? I mean, realistically.
I'm happy to. I don't think realistically much will change between now and Monday. We are in active negotiations with NFI. I mean, I just talked to Luke and checked in. So we can check in with each other again. I don't think there's going to be something major
Well,
by next week.
Are
because of
you
the short time.
creating, they're saying it comes down to one simple thing, building codes. Are you creating these building codes?
I'm not sure how that works because we don't get to create codes. They're governed by, I mean, CPT codes and the American Medical Association. We don't just get to make them up.
So is somebody, you must be a
I
code
did just
already.
update Luke that I got an email from my team talking about there are ways that we figure out covering the service, but it's maybe not under a specific code. Like it's not like Medicaid often has codes that we don't have. And so we have figured out ways to cover services, but we bill them under codes that exist in the commercial realm. I think that is what we can work out here. I don't think realistically I'm going to have something firm by Monday. But that is where we are.
Okay, well, we expect you to have that.
I have a question.
We expect you to have that, you know.
I have one more question.
Yes.
Was there something about a Senate bill, like 70 or something at one point that were you involved with that? And can you just explain a little bit about that?
So I remember I think it was 21, 22, 23, there were different iterations of mental health bills. None of them were an assessment like this. They were mandates for certain coverage of certain services. We've had many conversations with the insurance department, carriers, and other stakeholders around trying to line up sort of Medicaid coverage and commercial coverage. So there were those bills, but the first bill I'm aware of with an assessment like this was filed confidentially in 2025. That bill did not make it over to you because it was tabled by the Senate and then put in the budget. So this is the first time we saw this was winter of 2025.
What? Put it in the budget? Well, I would say this last year I was informed with things that were in the budget. Yes, that I was told. That's the first time I've heard of this. Okay, thank you very much. Okay, so is anybody else want to talk about 665? Okay. Oh, excuse me, what am I doing? It's 498. Anybody else want to talk about 498? Seeing none, then we will close the subcommittee. Okay, yes. So, not knowing what Thursday's going to be sessions or not, okay, my expectation is that from what we did yesterday, today, we have very few bills left over that still need to be discussed. So my attitude now would be to have a subcommittee next Tuesday morning on all the remaining bills, these ones that we've been holding over, that we get everything resolved. I will probably leave Tuesday afternoon open so that if some of those bills need to carry over to an afternoon or something like that, and then come next Wednesday, we will exec everything. And that way you'll be a week ahead of time, so, because I don't want to get yelled at by the House clerk.
You said 32 bills we had left to talk about. We had 32 bills total, and we've already.
Yeah, exactly, 8, yeah. Well, if I said 32, I misspoke.
The rest.
So we're planning on Tuesday and Wednesday.
Tuesday and Wednesday next week. And that way we'll be done a week ahead of time. So, all right? Okay. Unless you care about property and casualty, have a good weekend. Yeah.
That's this afternoon.
This afternoon. Needless to say, yes, I do live in my own little world, don't I?
Although I did hear Alcoa stock tanked about a week ago.
No, it didn't tank. No, it can't be that bad. You're right. Let me, let me check that. No, no.
About a week ago, I heard there was some issue.
No, a week ago, the announcement was that we sold a plant that's been closed. It's in upstate New York for years and years. We sold the plant? No. We sold it to a data center. So, so we unload that baby. That was a good thing. We got one of those data centers.
Oh, they reopened the
Right.
terminal out in the Midwest.
What the objection to data centers is? They're gonna use electricity and water?
Too much electricity and, well, the water recycling.
Not gonna use any electricity?
Oh, yeah, well, that's what it was. Aluminum was,
Sure.
but so that's the thing. Alcoa, all its plants were next to hydroelectric.
Sure.
So the whole Tennessee Valley TVA, Alcoa built all, this is a great story. Alcoa built all these TVAs, okay, the whole hydro, built all these hydro, built a bunch of aluminum plants. And when the war, and all during the World War II, the war effort, when the war was over, the government turned around and sold them and said the only company that cannot bid on them is Alcoa. And they sold them to R.J. Reynolds and literally it's ended because there was a year, it was supposed to be in the 50s or something, where my grandfather literally spent every day flying down to Washington, D.C. to defend us against antitrust. Because before AT&T, which was the big breakup, Alcoa was the case law for antitrust. And the reason being was when the companies first started, aluminum was more valuable than gold. Okay, because it's an element, it was more valuable. And so Alcoa's whole mission is how to make aluminum cheaper, cheaper, and cheaper. So that was considered antitrust because how can anybody compete if you're too busy making your product cheaper? So that's a great story, but the whole TVA was sold to Reynolds and Kaiser.
Because we need cigarettes, not aluminum.
And then the world has gone around, and now Kaiser, and all those plants are now owned by Alcoa, because the big competitor is Rio Tinto, which is out of Brazil. They bought Alcan, and Alcan all the people who were in Alcan were all former Alcoa people, but back at the turn of the century, owning international companies was passe. That wasn't good.
Right.
Okay, so they actually Alcoa spun off Alcan, and half the board of trustees, they all went to Canada, and then we were talking about A.V. Davis. We were talking about the nonprofits you see on the evening news. So A.V. Davis's brother Bruce Davis, he went with Alcan. A.V. Davis stayed with Alcoa, and then created all this money and he had no family, so that's why he's got the foundation donates to all these nonprofit, everything you see on TV. But literally Alcoa created its competitor and divided the Davis family in Alcan. But the funny thing with the Alcan was because it was in Quebec, Hydro-Quebec, they're all French, so they ended up merging with the French aluminum company. And then Rio Tinto took them over. So there's a lot of consolidation. At the end of the day, the biggest competitors now are China and Russia.
But the demand for aluminum has increased exponentially worldwide.
Yes and no. Aluminum is a marvelous metal. It can be alloyed with anything but lead. And Alcoa spent literally, the whole history of the company was trying to figure out things to do with aluminum. But at this point, aluminum is very plentiful. There's a lot of aluminum, but it's electricity. It's all about electricity. That's why you should recycle aluminum cans. It's a good thing.
On recycling aluminum cans, don't you get like 99% of the aluminum back?
Yeah.
99% of the electricity to make aluminum is, because all you have to do is just melt the aluminum and start again. Yeah, it's great.
You smelt it.
Okay,
562
what do we got here? 560, Home Damage Mitigation Resilience Program.
OTP.
Do we need any amendments to this bill, or these are all good?
No,
Okay.
it's good.
Who would like to be the champion of this issue? Aren't you nice to be here? Because you're not going to be here on Tuesday because you have a subcommittee on deeds. So deeds brings all that money in. What do you need to talk to them about your deeds for? Okay.
For Charlie. 562. 562. There's only two.
You're a county commissioner?
No, it's this morning.
Well, we all know our registry of deeds. Are you kidding me? My registry of deeds in Cheshire County, she was actually a legislator. She was on my committee when me and Paul were on legislative administration in Tilton.
You get the wrong day.
Well, because registry of deeds is your moneymaker. That's the only moneymaker we have for a county.
Every time I walk into the registry, she tells me that.
That's how important you are to it, right? Anna would tell you that, right? Right, except, Anna,
Can we get done with this meeting?
okay, all right, motion is by Representative Bertelli, seconded by,
Who's here?
who? Thaxton, yes, okay. Thaxton, moves, ought to pass. Yeah. 562. Okay, ought to pass. Any discussion on the motion? Okay, so who's, Porcelli, no, that's not, I got, what am I? Insurance, yeah, Porcelli, same people, they all,
Everyone but Miles is here.
Miles left, okay, okay. All those in favor say aye. 1, 2, 3, 4, 5. Okay,
50.
5 zip. Okay. 5 zip. Okay. Senate Bill 565, requiring the Commissioner of the Insurance Department to prepare and publish a report regarding fortified home and commercial standards and other mitigation and resilience programs. Any amendment for this, baby?
Well, how much work is this going today? Because I think we already heard that it's already produced in other forms. And it's just gonna tell people, don't buy homes in flood areas.
No, that was,
What's your,
that's the bill, those are other bills that we had.
which the bank from which you're getting your mortgage would probably advise you of anyway. But no, this will not be a ton of work for the department. And in good faith with Senator Waters, who, when he first proposed or brought forward this legislation, there was a lot going on, and we worked with him and we narrowed it down to something that is reasonable and, most importantly, would be useful. So we're very comfortable with what you have in front of you.
Any other questions?
There we go.
So,
This is going so much better than this
wait,
morning.
no, I'm not done, I'm not done with you.
Oh,
So, is it gonna, you say the department can resourcefully, do this program?
yeah. So
So-
a lot of the information that is contemplated under this legislation is material and data that we collect at present. So we're just augmenting the core of what we're going to put together already. So adding some additional information and data into that work, again, it's a minimal amount of extra effort on our part.
So I have just one question. You're gonna love this one. You have money for that, but you can't do the RX program?
I didn't have a problem with the legislation with the RX program. It was enabling legislation. And if that legislation were to have gone forward and we were to begin seriously having a conversation about entering into that type of arrangement, I would bring the stakeholders who said that it would not be any extra staffing or resources in to explain to me and give me more detail how.
Okay, but in this case, when it comes to the fortified home resilience, you don't need anybody to come in and tell you how.
We will be fine.
Perfect.
All right.
Can I ask a question?
Sure. Oh, they have one more.
What is a fortified, I've sold real estate for a long time, and I've never had anybody say, I have a fortified home. Can you tell me something with gun slots?
Yeah, there is a little bit of personal definition, I suppose, that works its way into that. You know, in terms of Senator Waters' proposal, I think Emily might be able to better speak to that. You know, as it pertains to the previous legislation for our program, you know, fortified home is a technical term mostly associated with the IBHS track that you can go on that gets you the official seal of approval from carriers as being a fortified home. As I said, if people want to go down that road, absolutely, I think it's a great thing. It's going to involve them having to make a financial investment to do all of the things necessary, but it doesn't, you know, again, our program doesn't force you down one track. You can do some other things to benefit. But in the context of this, Emily, go ahead. Yeah, line 21, section 2.
That's just what I was gonna say. It's in the bill. It's at lines 21 through 24, and it says for purposes of this section, fortified homes and commercial standards and other mitigation sorry, I can't speak. Resiliency programs means measures taken to reduce loss due to extreme weather events such as precipitation events, storm surge, coastal flooding, high winds, and hurricanes or hail. Is that
Gee, I wonder
helpful?
if my castle qualifies.
That is very fortified.
Yeah.
If you,
Guns.
and if you put the moat around it,
No,
then
no,
it's
that's the
very
whole-
fortified.
That is like the number one question people ask me, you know, where's the moat? And I go, no, you have to understand, the only castles that had moats were in Denmark and where they were in where they didn't have a mountain to put it on. We're on a mountain. We're on the knoll. We're on the high point. So that's why we don't have any.
I assume that putting the alligators in the moat, that was made up, right?
That is only in fiction. There's never been any castle that ever had
No gators in
alligators.
there? All right.
Well, because, you know, I think the alligator would have a little problem in the winter time.
Those guys, you know,
Denver.
can freeze,
And-
can
and-
totally
and-
freeze and then come back to life.
Right.
They're
And-
incredible creatures.
Well, just like turtles.
That's right.
Yeah, we had one of those turtles. So it was still hibernating, and it was just floating in the water, and I thought it was dead. And so we went and grabbed the tail to throw it up on the road, and he woke up.
Yeah. Yeah. My 8-year-old son's mind was blown when I said, you know, all the dinosaurs are extinct, but there are some animals that were around when the dinosaurs were, and alligators and turtles were too.
And our summer
Sharks
home,
and horseshoe crabs.
horseshoe crab. Our summer home is full of dinosaurs. Yes.
Yep.
Okay. All right.
Very good.
Thank you very much. Representative Pacelli moves to pass. Thaxton seconded. Okay. Any discussion on the motion? All those in favor say aye. 1, 2, 3, 4, 5. Okay. All right. We're all done.
See you next Tuesday.
Okay.
See you tomorrow.
What did we decide with the 661 pooled risk management program?
Next Tuesday.
We're going to vote on it next week.
By the time you get home, the calendar will be out.
Uh,
We love that as politicians. Because you know Rob, he's that.
My son's
No.
not a politician, and I disagree. I don't think I'm a politician. I think a politician would get paid far better.
But that's why I tell people